Good morning and welcome to Sunday Sunrise. I'm your host, Vicki Carmona. I'm here with Dr. Dan and Dr. Hodgson. Good morning, guys.
Good morning.
First of all, thank you so much for coming in today. But before we get started talking, go ahead and tell us a little bit about yourself. We'll start with Dr. Dan.
All right, Vicki, always a pleasure to be in here. And I am Dr. Dan Graham, chiropractic physician out in the East Valley here. And we have medical doctors in our office. I'm a chiropractor by training. We have a full gym, personal trainers. I've been the chiropractor for the Anaheim Angels for 4 years in the past, and we just glad to be back here on the radio again with you.
Fantastic. It's always great to have you in. You are very knowledgeable, and you've definitely done quite a few topics in the past.
Yeah.
But Dr. Hodgson, you are new to our studio, correct?
That's correct. And Vicki, Dan, thank you so much for having me this morning. My name is John Hodgson, and I'm a neurologist in Gilbert, Arizona. I have a practice, Gilbert Neurology, right near Mercy Gilbert Medical Center. And I'm also the stroke director at Mercy Gilbert. We've just started a new stroke program there, as well as at Chandler Regional Hospital.
So we're here to talk about migraines today, right?
Yes, migraines.
Now,
headaches.
Migraines are what, just headaches that hurt a little bit more, or what are they?
So that's a good question. Actually, migraines themselves are actually due to abnormal neuronal firing. So it's actually your brain neurons firing off abnormally. The pain is secondary to that. So people actually can get migraines without actually having a headache. It's kind of weird, but it happens. So you have this abnormal neuronal firing, or the brain cells firing off abnormally, and that then triggers the pounding, throbbing type headache. And so typically we describe a migraine as having pounding, throbbing headaches that either on one side or both sides can last for at least for a few hours. The pain's fairly severe. Typically they may have light or sound sensitivity associated with them. They may have nausea and or vomiting associated with it. And so that's kind of how we describe a migraine headache. Now, sometimes people may also have what we call auras prior to a migraine. An aura kind of is kind of a warning that the migraine is about to occur. People may describe dark spots or bright spots in their vision, or squiggly lines in their vision before the headache starts, or they may have weakness or even numbness on one side of the body. Last week we talked about stroke, and sometimes people these same symptoms can be consistent with stroke, and so it's sometimes hard to delineate between the two. But that's commonly what we see as a migraine itself, and then after the headache, people feel pretty bad afterwards, and typically they have to sleep the headache off. So.
Oh, wow. So I always thought like a migraine was a headache that just hurt more, but it's actually way more than that. It sounds way more serious.
It can be potentially serious, and a lot of times people don't realize that how often they're actually having headaches, and they just kind of take Tylenol or Motrin and just kind of deal with their headaches, and so there's a big push to get awareness out there of possible options for treatment and ways to prevent headaches, and so it's definitely something that people don't have to continue to just suffer with headaches per se.
Mm-hmm. Well, I know that a lot of men, especially that I know, when they get a headache, they refuse to take any medicine whatsoever. They just, want to tough it out because, they're men, I guess.
Yeah.
Is that the best way, or should they actually go ahead and take that Advil or that Tylenol or whatever it may be?
Typically, we have a kind of a two-pronged approach to headaches, and there are a variety of different types of headaches. Migraine is a single type of multiple types of headaches out there. But the key for treating majority of headaches is if you're going to treat them as soon as they start. Don't wait, because a lot of times if you wait an hour or half hour into the headache itself, medications won't work. And we typically start off with, if we're going to take something, we typically start off with the over-the-counter anti-inflammatories like your Advil or your Aleve or Motrin, Excedrin, and we typically use those. If those don't work, we go to a second class of medications called the triptans, which are more migraine-specific type medications, and sometimes we use these in combination with anti-inflammatories or anti-nausea medications to combat a headache when it occurs. So you have that abortive therapy out there for migraines. And then when we start, I see many patients in my practice with migraines, and we try to help people identify potential triggers for headaches. Some people can identify triggers for headaches, and so that if they avoid certain triggers, that may affect the headache itself. And then the second step is having patients keep diaries of their headaches to really see how frequent those headaches are occurring, because there are also options out there for preventing headaches. There's a medication that can be taken that actually suppresses the headaches, and so people don't necessarily have to suffer with headaches. And so it's a big thing about education. There's things you can do about headaches to potentially abort them and or prevent them, depending on how frequent they are or how severe they are.
Okay.
And sometimes headaches can be due to different triggers, like nitrates in their diet, and red wines, and different things.
Dan brings up a good point. Yes, there's many different triggers out here, and not all triggers are specific for everyone, but one of the common ones we see would be lack of sleep can trigger headaches, skipping meals can trigger headaches, certain foods definitely trigger headaches, nitrates as well as certain cheeses and alcoholic beverages can trigger headaches. In women, hormonal fluctuations, so one's period can also trigger headaches, and so very, very many triggers out there for certain populations.
Okay.
Now, question that I have is depending on when I was coming through school, we were taught you had different types of headaches. You had the migraine, you had the cluster, you had the tension, different types.
Mm-hmm.
And a few years back, I saw some research that came along that said, okay, now that we have more advanced brain scanning techniques, that what the research had shown was that they're all the same headaches, just at different severities. And so I saw where that was kind of a leading theory on headaches. And then over the past few years, I've seen where it's kind of gone back to, the different types again, and they are truly different. So can you kind of enlighten us on what the current thought process is on that?
Yes, that's actually a good question. So the International Headache Society is the group who kind of formulates the names and terms for different types of headache classifications. Mm-hmm. And there are different types of what we call pathophysiology with certain types of headaches and different treatments for them. There are certain class of medicated headaches called indomethacin responsive headaches, and those headaches are only responsive to a medication called indomethacin. So, and they have different reasons for occurring and different treatments. So, one of the second common most headache is a tension or what we call cervicogenic headache, which I'm sure you see a lot, Dan, and it's treated differently somewhat than the headaches that we more classify as migraines. So. Different approaches to different types of headaches. Mm-hmm. And it's important for a physician to identify what type of headache, and sometimes people will have a combination of headaches. Mm-hmm. One of the common things we see, the most common thing on top of migraine and tension type headache is something called medication overuse headache or rebound headache, where people are using too many over-the-counter medications, too much Tylenol or Motrin or Advil, and it leads to a rebound phenomenon with the headache. So the headache goes away, they take the medication, and then headache comes back and they take more medication. And it becomes more of a chronic daily headache because of the medication overuse. And so really delving into the history of what someone's doing with their medications and how the headaches are occurring and where it's located, the better idea of how we can best help a patient out with the headaches themselves.
Now with headaches, we'll also have the caffeine type headaches where you're constantly taking a vasoconstrictor, which is limiting the blood flow into the brain, and then once a person tries to get off of coffee or Coke or whatever it is, they lose that stimulant, and then the brain has a rebound effect where all of a sudden now it has this overdilation, which can cause the headaches.
That's true, and caffeine can be used in a couple of different settings. It actually is a decent abortive therapy. It actually can help break a headache in certain instances, but if you use it too frequently, and it can lead to continuous headache as well. Stopping it abruptly can lead to a withdrawal headache from the caffeine itself, and so it definitely can vary on how it's being used and how often.
Now, explain. Doc, by training, you're a neurologist, but you went to osteopathic school. Mm-hmm. I went to chiropractic college. Mm-hmm. When we deal with these cervicogenic headaches, and you in the past and currently, and myself, we adjust the cervical spine and can relieve headaches. Explain that.
Well, I think there's a huge portion of what we call cervicogenic headaches is due to muscle tension and muscle tightness, and that can lead to kind of knots in the muscle itself, as well as it can offset the positioning of the spine itself, and that in itself can trigger nerves to become painful. And so addressing the curvature of the spine and resetting the facets or the joints in the neck itself, as well as alleviate the tension, in the muscles in the upper back and neck can significantly improve one's cervicogenic type headaches, and sometimes they'll actually trigger migraine headaches. And so we try to really focus on dealing with that issue, as well as postural correction. We see this kind of float posture, extended neck kind of thing, where people are kind of leaning forward all the time throughout their day, working at their computer, and that can lead to these chronic cervicogenic headaches. And so postural correction is one of the biggest things I tell patients to get their shoulder blades back all day, every day, throughout the day, because that's a huge trigger for cervicogenic headaches. But just manipulation of the muscles itself, as well as realigning the spine itself, can definitely relieve headaches in certain patients.
Okay. And one thing I do want to ask is, before we move on, you guys mentioned a ton of different types of headaches. And now when you go to the drugstore, or you go to the store and you go to get your headache medicine, there's an entire wall of different types of medications, different brands for different types of headaches. What should people look for? I mean, do they have to go to the doctor first and get their specific type of headache identified? Is there a risk in taking isn't necessarily for their headache as well?
Well, I think that most anti-inflammatories are medications that are used to treat headache, your Tylenol, your Advil, Motrin, Aleve, Excedrin, or the generic equivalents, are very good for aborting a headache. And most of them will work for both types of headache, both the migraine headache as well as the tension type headache. And so the biggest thing is to make sure they're not being used too frequently. And if they're using too frequently, that can be leading to what we call that medication overuse headache. And if they're having frequent headaches, they need to talk to the physician about options for preventing the headaches rather than just taking medication when it occurs. We typically have patients come in and they're having headaches 3 or 4 times a week, and they're taking medication and it's working, but they're taking medication and they're dealing with these headaches, where we can talk about medications that actually would take every day to actually prevent the headaches from occurring, and so they don't have to suffer with these headaches.
Okay, and you said that people get the headaches like 3 times a week. Let's say, what's the typical guideline for somebody to go to a doctor to get some advice? How many times a week should somebody not be getting a headache?
I think if someone's having more headaches than probably 15 per month, that's fairly frequent. And so at that time, I think it's worth talking to one's family physician about. Or if the headaches seem like they're getting worse with time, then that's a concern. Probably want to talk to a doctor. A lot of times we see patients in the emergency room or urgent care with their worst headache in their life, and those are probably reasons to be seen by a doctor too. Or if the headaches, if they've had headaches in the past, but they're changing in character, they're acting differently, that's another reason to see a physician in regards to the headaches. But the big thing is to just keep an idea of how often they're having them, and keep a diary, which can be helpful for their physician to see how frequently they're having them, and then try to identify certain triggers that may be leading to them, because diet and lifestyle modification can make a significant improvement in some patients with fairly frequent headaches.
Mm-hmm. Now, I know a lot of people are very hesitant to go to their doctors, especially for something that people think like headaches are very, very common. Is there a reason why they should go specifically for headaches? Can this be a sign or a symptom of something else?
So that's a good question. If you just deal with the headaches, is there anything going to happen to you bad per se? And most times if people have chronic daily headache or chronic migraine or chronic tension type headache, they won't have any significant long-term adverse effect. We do sometimes see actual injury in the brain itself from migraines, especially if they're very frequent. So that's one reason to consider if you have fairly frequent migraines, is to see a physician, as that can cause injury. We also notice that people who have fairly frequent headaches also have other symptoms. They'll have complaint of cognitive impairment. They'll have difficulty with word processing, or short-term memory issues. They'll complain of feeling dizzy or unsteadiness that's persistent. They'll complain of fatigue issues. And if you address the underlying headaches and suppress those headaches, a lot of times the cognitive issues, the dizziness, and the fatigue issues will actually improve, and people will feel better. And so another reason to consider treating the headaches if they're fairly frequent, because it can cause other issues and affect their quality of life. So.
Oh, wow. So definitely get on top of that, right?
That's right. That's true.
Have you ever had a migraine, Vic?
I've had really bad headaches, but I'm never sure, because everybody says that migraines feel this way or that way, and I just kind of deal with it, I guess.
You know what's interesting? We see a lot of patients with headaches in our office, and I'm always taken aback because I might get one headache a year. You know, it's pretty infrequent for myself, and I see patients that have migraines every single day, and I couldn't even imagine trying to go through life, you know, much less a headache every single day. And it's fairly fascinating. You know, sometimes when you meet patients, you know, they're just like, oh, that's just common for me, and but it brings to the fact of the other thing is that sometimes when we have these chronic headaches and the underlying issue may be not being addressed, taking over-the-counter medication can have some effects on the liver and the kidney over long term.
That's true. That brings up a good point. Yeah, these medications over the counter are not do have risks to use them too frequently. Outside of just the headaches itself, and affect problems with the GI system or the liver and the kidney, as Dan was alluding to. So. I think it's definitely one caution has to be taken to when one uses that type of medication too frequently, because they're not just safe per se, especially if they're used that way. And there's other approaches to headache management too. There's acupuncture has data out there for headache treatment, as well as naturopathic and supplemental approaches, supplements that are helpful for headache prevention or treatment. So there's many different ways of treating headaches depending on the type of headache and what may be playing a role. But the biggest thing is people don't have to suffer. I've had patients that come in to see me, they've had daily headaches for 5, 10, 12 years, and we get them on medication, they're headache free, and they're like, I didn't know I could take a medication and be headache free. And so it's a huge thing that people just need to be aware about, that they can seek treatment if they're interested.
Okay. And I do have another question, because from what I understand, it might be a myth, it might not. Do women really get headaches or more than men? Because that's what you always hear, right? Yeah,
we definitely see migraines much more frequently in women, especially as girls enter into the menstrual cycle. Menses in itself, or having a period, that fluctuation in hormonal levels can trigger headaches, and they can persist into adolescence, into teenage years and early 20s. And sometimes the headaches go away for a period of time, and then they may come back around menopause and but change in character or act differently. But I see patients from anywhere from 12 and 13 start having headaches to women, to a variety of men and women having headaches in the 80s and even early 90s. So it can involve the whole lifespan, but most commonly we see it in that in women around the menses starting and through that early 20 period, and then sometimes around menopausal type time and with the migraines itself, but much more frequently in women than men.
Oh, wow. Okay, so that is not a myth.
No, you were right.
No, you said it's mainly women, younger women, but it can affect everybody.
That's correct. We see headaches in all age groups in our office, but typically that's when it starts. But it can worsen as they mature with age or get older, and sometimes they'll go away with time, but come back and they can be fairly debilitating. And so when one wants to treat a headache, it's important to really address it early on in the headache cycle and get it treated early.
Now, Doctor, there's also some other things that I want to bring up, is that the brain has, correct me if I'm wrong, brain has lots and lots of pressure sensors in there. And our brain will sometimes perceive this pressure as pain. Now, other issues that we have to be made aware of is that you can also have starts of infections that'll come on as headaches. You can even have tumors that come on as headaches. And is there a way to delineate between those?
Yeah, there's certain red flags that we look for when we're concerned that, okay, this isn't just a typical migraine or a typical headache. Some of the red flags are any type of fever or chills or flu-like illness with the headache itself is a concern, and a headache that is progressively worsening with time, or headaches that wake one up in the night multiple times a night or getting worse with time. Sudden, severe onset, worse headache in their life, that's a concern that something else may be going. And those types of, if one has those type of red flags, then it's important to get a more urgent evaluation and seek evaluation by a physician if that is occurring.
And it's fairly interesting too. Some of the headache patients that will come in, part of their aura or their prodrome for the migraine headaches is I'll have patients where they come in and all of a sudden, just like that, they'll lose total vision in one eye.
Wow.
And we've seen auto accidents come because of that, where they just come on like that, and then all of a sudden, they start. really panicking. I mean, if I went blind in one eye, I would certainly panic.
It's kind of bizarre, some of these auras that people get. And actually, that's when you want to treat the headache, is when the aura comes on before the pain starts. You want to treat the aura at that phase, and that'll actually sometimes prevent the actual headache from occurring. But people have some losing portion of their vision, and they're outside their vision, or they'll look through a tunnel, or they'll have these bright lights or dark squiggly lines in their vision. They'll have stroke-like symptoms, as we were talking about. People actually can lose consciousness with migraine, so can be, and people actually can have a stroke from a migraine itself. So those are more severe type headaches, but can happen.
So basically, the lesson is that migraines are real and they're serious, and definitely get them checked out, right?
Exactly. Try to identify triggers for one's headache. Keep a diary of headaches. Treat them early on. If they're fairly frequent, see a physician to address them, because you don't have to suffer with them.
Fantastic. All right. So I guess we are running out of time. So, Doctor, is there something that you want to add? Something that you want to leave the listeners with?
No, I think that's the biggest thing, is we identify the headache itself, treat it early on, make sure you're not using medication too frequently. If headaches are becoming more severe, more frequent, seek your family physician, and they may give you guidance to a neurologist like myself who does deal with headaches fairly frequently, and you don't have to suffer with headaches. You can get headache freedom.
All right, Dr. Dan?
I second that. A lot of we'll see a lot of patients with headaches in our office, and especially after auto accidents. It's a very, very common thing to see where the cervical spine has been disrupted, and there's certain procedures that a patient needs to go through to address whether it's traumatic, whether it's cervicogenic, migraine, and I'm glad to be associated with Mercy Gilbert, where we can get the patients right in to see some of these good doctors like Dr. Hodgson here.
All right, fantastic. Great. Once again, thank you both for coming in and talking to us about migraines.
You're welcome.